morning all. Welcome to CE session. I'm going to be critically appraising a clinical guideline today. So, this is the clinical question we have. The 50-year-old male who is a known diabetic for the past 8 years is under follow-up for diabetes mellitus type 2. He's been on metformin and glimepiride for past few years, maximum tolerated dose, and his latest HbA1c during review is 8.8. He's also found to have complications of diabetic nephropathy. So what is the next line of drug which can be started for this patient for glycemic control and to delay the progression of complications due to diabetes like diabetic nephropathy? I would like to look at data which would compare between different drugs, and he is already on the primary drug treatment. So for this, I have gone through literature and found this clinical guideline which is published in Annals of Internal Medicine on April 19, 2024. So this is the guideline is titled Newer Pharmacological Treatments in Adults with Type 2 Diabetes, a clinical guideline from the American College of Physicians. So for this, for a guideline to be appraised, there is a tool called Appraisal, which is Appraisal of Guidelines for Research and Evaluation, the Mark 2 basically. So we have given few copies of it. So this is similar to CAST questionnaire. It has a lot of domains, it has a lot of sub questions, and there are things and criteria as to which how you can actually rate the guideline itself. So agrees, who can use an agree? It could be healthcare provider who wants to do his own assessment like us probably, and guideline developers like probably people who are actually writing down guidelines as to how to follow to what and all is necessary to be incorporated into forming a guideline. Policy makers like government people and even institutional people, and educators like this session where we are trying to help people understand how to use this tool. So there are a lot of items. It's an exhaustive item which has 23 key items within 6 domains, and there is a 2 global rating items after that. So there are 6 domains which read scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. We'll go into each a little bit in detail. So I'll start off with the domain 1. So I'll just a little bit before that, there are criteria as to what you can check in each of the parts of the guideline. And there are two other things, like other things which they given importance for is whether the guideline is clear, is it concise, it is easy to understand, is it precise, like is it easy to find on the guideline. Those are some things which have been given importance for the rating, apart from the actual points where we will discuss more about. So domain 1 is scope and purpose. The first question is the overall objective of the guideline specifically described in the guideline. So they have, I have rated it as 7 because they have put it up in the guideline that the intent of the guideline is to update the guidelines of treatment with type 2 diabetes according to ACP. The last guideline by ACP was in 2017. They have updated it now and re-released as a new one. So that is the intent of this guideline. And what is the research question or the questions they have thought about in the guidelines is what is the effectiveness and harms of newer OADs used either as a monotherapy or in combination with other medications, and they try to answer this question in this guideline. So second question is the health question covered by the guideline is specifically described or not. So they have included this 5-part statement in the supplementary. It was a little unclear in the guideline itself, but they mentioned it in the supplementary clearly. So population was non-pregnant adults with type 2 diabetes. Intervention was any of the newer pharmacological treatments as mentioned here. And comparisons was usual therapy, placebo, or even among the newer OADs itself. Outcome they looked for is all-cause mortality, MACE, stroke, progression of CKD, MI, serious adverse events, and important outcomes which have been also looked for is congestive heart failure requiring hospitalization and severe hypoglycemia as an adverse effect. So the setting they have mentioned for this guideline is outpatient. So they have mentioned specifically about the health question which is covered in this guideline. So third question is the population to whom the guideline is meant to apply. Is it specifically described? I have rated it only 3 because there were some issues I found. So they have not mentioned anything clearly as to whom you can apply this guideline to. It's not very clear or concise. I had to go through the guideline a little bit in detail to find that patients who are adults with type 2 diabetes can be applied, plus with or without CKD, with or without cardiovascular disease. And they have also mentioned somewhere very, it's not very clear enough, that long-standing diabetes people with HbA1c level of around 8% despite the use of usual care, those are the people you are actually supposed to. So if you don't read the guideline clearly and appraise it, you might use it for anyone, even 11, 12. It was not specifically mentioned somewhere which is not clear on the guideline. Again, that is one reason why I have downgraded it. Also, there is no exclusion criteria as to whom you cannot use it. They have not mentioned anywhere about who you cannot apply it. There's one line where, like in a corner, where they mentioned pregnant individuals cannot be given. So they have not studied in those studies. So obviously they had to rule it out, but they should have mentioned it clearly, which is not mentioned. Again, some other studies which were not included in the systematic review which was preceding this guideline was hospitalized patients with type 2 diabetes in acute comorbid like acute stroke, acute MI patients, type 2 diabetes undergoing surgery or active cancer treatment. So we would most likely that at least like 30-40% of the times we might find these patients coming to us and we finding them to be newly diagnosed as diabetic. And could we apply this guideline? No, but it was not clearly mentioned because they didn't use those studies, appraise these studies as part of the guideline. In established CKD versus CKD and cardiovascular disease without non-established or non-established CKD, CKD, those differences were not mentioned. So there are a lot of exclusion criteria which is not, or the people who did not apply, this did not apply, it was not clearly mentioned is what I first have downgraded it to 3. So going to domain 2, stakeholder involvement. So as sir said, stakeholders, we have already talked about who are the stakeholders. We will go into individual questions and answer how did they fare. So the guideline development group includes individuals from all relevant professional groups. So a guideline should be involved by it should be formed by appropriate individuals, professionals, non-professionals, So this is by American College of Physicians who have a guideline per se as to how they should form a guideline. They have a CGC, which is a Clinical Guideline Committee. So which is a set committee which has 14 members, of which 12 members are internal medicine physicians of various specialties, and they also have a public panel and topic expert panel. So I have downgraded it to 6 because they have not mentioned as to, so as per the agreed rule, they are supposed to mention about each of these 12 members in detail as to what specialty they are, where do they work, what are their interests in, what are their research on, which is not clearly mentioned in the guideline. It was not even in the supplementary or anywhere else which I could find. So I am worried, was it appraised by appropriate specialty people? Internal medicine is fine, but was an endocrinologist involved, was a diabetes specialist involved? Those were not given, so that's why I have not. But they have used internal medicine physicians who are good enough to appraise it though. So then they also have a public panel. Public panel is entirely made up of people who are from public, non-physician members, and also members of the topic expert panel were included to find out whether the importance of the clinical outcome is critically important or less important. So of these, but 14 members were physicians. Even in the CDC, there are 2 members who are non-physicians, who are adequate, who had the layman perspective of the guideline to appraise on. So also they had a topic expert panel. So they mentioned clearly, but could have mentioned the details of each of the members, which was not done. So these members were given these key questions as to how to appraise, what are the questions you need to go through to appraise the systematic review and get to that guideline, which is mentioned clearly. So again, the views of preferences of the target population. So this is what I mentioned as the CDC public panel, which is non-physician CDC members. It was selected, and I've gone into this is the article where they mentioned about the ACP's guidelines to make guidelines. So where they mentioned that the public panel is not selected based on the disease itself. There is this general public people who come and give their own perspective as to what might be important outcome for them. In place of all the people who are actually having the disease, which is not right. They should have included some people who actually had their disease, is what I feel. So I downgraded it by 1 to 6. How did they do it? How did they get their perspectives? They did surveys to collect their opinions and also asked about preferences and feedback. So that was mentioned rightly. So what are the outcomes they had given? So they had given these outcomes to them and asked them to vote on which do they think is the best outcome for them. And they have probably more adequately they have checked because all-cause mortality, congestive heart failure, the appropriate ones have been chosen. The weight change was another one which they thought. So whether other outcomes which might have been chosen by people who actually had diabetes, possibly, which was missed here. So other than that, who are the target users who can use these guidelines? So they have just mentioned a common phrase saying intended audience is physicians and any other clinicians who wants to use this, who can treat diabetes. Could have been like more specific as to which level they can use. They have mentioned outpatient, but primary, secondary, tertiary care level, and could have been more elaborate as to, because the availability of drugs may not be can't throughout all levels of care. Again, this was in the US, possibly they have it everywhere, but could have mentioned clearly that it was made available everywhere so they can apply the guideline. So third domain is rigor of development. There is a lot of questions about this. I think rigor of development of this depends on this article which we appraised 2 weeks ago. Dr. Thomas had done it, and based on this, these guidelines have been made. So I will not go into appraisal of this again. I will just answer the question straight. Systematic methods were used to search for evidence. We do not strongly agree. We have downgraded by 1 because they did not check newer trials, ongoing trials and all this. And non-English studies were not included. Non-US studies were not included. Could be okay because they wanted to make a guideline for US, but still could have seen at least the current ongoing trials which was missed. Other than that, the criteria for selecting the evidence, as in the PICO statement and all those in the systematic review meta-analysis was appropriate. Strength and limitations they have graded accordingly based on the evidence using the grade recommendation, which is also done. So we will not go too much into that. So methods for formulating the recommendations. So how did they do it? It was properly mentioned. They have quoted this, which I said this is the guidelines of ACP to form for the clinical guidelines committee, which they followed clearly. This is the guideline for any guideline they want to make. So as sir had said about a flow chart or flow of how a guideline is made, the topic is selected, develops the PICO, the CGCA public panel rates the outcomes which we saw, and then external evidence review, the systematic review is done by the panel. Also at the same time, like they also do it with the agreed tool. In agreement with the agreed tool is how the guidelines have to be made. Then a clinical guideline and statement is done. The full committee then discusses, finalizes and approves the recommendations. So which was clear, this is still the recommendations are formed. We will come to the later part a little later on, but this was appropriately mentioned. So health benefits, side effects and risks have been considered in formulating the recommendations. So yes, so they gave a summary. This summary was based on the systematic review which was done. So they have given clearly the supplementary about in a layman language how you can actually see whether there were effects, uses or adverse effects, whatever. So did the guideline show an explicit link between the recommendations and the supporting evidence? Yes. So they have mentioned in the guideline, but this is a summary of the guideline. You can see that they have clearly, and it's very visibly easy to understand that there are only 2 drug choices which can be useful in certain situations in type 2 diabetics. I will not go into the details because we have already appraised this as a systematic review. So this is based on like this. They also gave as to what they mean by strong recommendation, what they mean by conditional recommendation, and they given as to how you can actually like understand the recommendations itself or take it as percentage of how you can use it. So strong confidence that the benefits clearly outweigh the risk. Conditional, probably, but there is an uncertainty. So they left it to the clinical judgment also. The guideline has been externally reviewed by experts prior to its publication. So the next step after the recommendation is to be reviewed by peers, which was done, which is mentioned as peer review process was done. They have mentioned that the guideline was posted. They have gotten opinion from all the ACP people who are members of the ACP, and also they asked for comments before finalizing. But what were the results of those reviews? What did they find? Did they find any problems? It was not mentioned. They just mentioned everything was done and it's all fine, which was not right, I felt, and they should have mentioned clearly as to if they found something wrong in that and they rectified it or not. So this is part of the rest of the guideline flowchart, where once the recommendations are formed and finalized, then the CDC public panel reviews. The ACP board had reviewed it and they have made a comments which was submitted, and then they once the review is done, then they disseminate it. So this is what they have done, but they have not mentioned what the intricacies of it even in the supplementary. So process for updating the guideline, that was the next step. So updation of guideline was not clearly mentioned anywhere. They just mentioned clearly that guideline expiration. So automatically they felt that 5 years is the correct time for the guideline to expire in case there is no other new guideline which comes in that period. So no guidelines regarding how they're going to update, how they're going to include the newest studies and probably update in 2-3 years. Something should have been given which is not given. At least they gave that if a new guideline doesn't come in 5 years, just consider this to be expired. So I've given it 3. So domain 4 is the clarity. So is it all like when you read the guideline, is it all easily identifiable? So the recommendations are specific and unambiguous. For this one, I've given, this is the criteria which is usually given for each domain. I've mentioned it here so that we understand a little better, because this is the final part of the recommendation. So is the statement of the recommendation clearly given, the identification of the intent and the purposes. So identification of the intent and identification of the relevant population, and if there are any qualifying statements, if any. Then additional, as I said, it's always about whether there is any uncertainty, clarity. So they did not mention clearly in the guideline itself, but this was given as a separate visual guideline on the website, but not on the article, but I'll come to that. So they mentioned here that adults with type 2 diabetes, the population was clearly mentioned in this is the recommendation lines, and inadequate glycemic control. So they have also mentioned that the drug, what are the actual drugs or the intervention, what is the outcome you want to do for, and to reduce the risk. So they have clearly mentioned what each line means, and it's appropriately done. The recommendation is also appropriate. And they have also given a strong recommendations against PPP4 based on the evidence. So it's also clearly given as to type 2 diabetes. There is no changes in the modifications in the type 2 diabetes with inadequate control in all-cause model. They have clearly mentioned as to what the recommendation means. So this was well done. So there are different options of management, as we already saw. They have mentioned as they clearly, as in there is no confusion as to what is the other drug you can use. So that was also clearly done. But was it easily identifiable in the guideline? So if you take the guideline and read it, you might find difficulty in finding out where the guideline, the recommendation is actually on. It's the paper clarity which we are talking about. I had to go into the website as per this URL to find this guideline recommendation with adequate evidence given on the site, which is good on the website but not on the paper. So fifth domain is applicability. So applicability, the first question is going to be the guideline describes facilitators and barriers. So facilitators and barriers means for the guidelines to work, what are the things which are necessary, and what things if it's there, then that will be a barrier to the application of the guidelines. So they have not clearly mentioned about facilitators and barriers. You have to read through it and understand probably these could be what they mean. So they have mentioned that the clinician should reduce or discontinue existing treatment due to increased risk of hypoglycemia when they are adding SGLT2 or GLP-1, which is actually bad. You can take it either way, but if it's not read properly, people might use it just like that. The benefits and harms should have been thought of. So the knowledge of these benefits and harms could be a barrier to use of this guideline also. And they also mentioned that to avoid polypharmacy, there should be a communication between the pharmacist and the team members, which could be a barrier to application of this guideline. So they have not mentioned in the guideline that this could be a barrier, and please be cautious. So no direct mentioning of what factors could be facilitators or barriers. So I've rated it a little low, but you could understand if you read it in detail. But that is not what a guideline is for. It should be just there so that people can understand just like that easily. So the guideline provides advice or tools on how the recommendation should be put in practice. So that is clearly mentioned, but one thing we thought was it could have been put as a flowchart where it's easy to understand. So as we have been reiterating, it's not about the evidence, it's about the clarity of the guideline document itself, which is not there. But they mentioned as words that adding SGLT2 in patients with type 2 diabetes with CHF or CKD, and adding GLP-1 for type 2 diabetes with increased risk of stroke. See, these are the situations where you can apply this drug to, which is appropriately mentioned. So they also said that you cannot use it as a first line treatment because there are no evidence, and they also mentioned that what you should do when you are applying these drugs to reduce or continue the existing treatment based on whether there is any risk for hypoglycemia, which we saw already. So this was done, but a flowchart would have been better. So what is the potential resource implications of applying the recommendations? Was it considered? So this guideline also was like preceded by a cost-effective analysis. After the systematic review, there was a cost-effective analysis which we did an appraisal on last week, which included every cost: the cost of the drug, the pharmaceuticals, the getting the drug here. Everything was included, including the adverse events of the drug itself, the cost of treatment for that. Everything was included, and we had this. This was the review, the article which we saw based on which was a cost-effective analysis, systematic review. And we remember this from last week where they had made it as high value, intermediate value, low value. And SGLT2 and GLP came in the high and intermediate value. That's why they've come up with this guideline to use it. They've also mentioned about how the value threshold is reached with the economic evidence, and they've quoted this study, which is appropriate. The guideline presents monitoring and auditing data criteria. So the monitoring is post the guideline, was the monitoring of what you need to monitor. That was mentioned, that was not clearly mentioned as to what you should monitor. They just says like try to get the HbA1c level 15-7. It was very general guideline which they mentioned, and they wanted to have an individualized glycemic control based on the patient itself. So auditing criteria is what, after dissemination of the article or the guideline, to follow up, is it working well or not? Was there any problems? Was there is it like appropriately done? Is there any adverse outcomes? So that there can be an update in the future, which is not which is not given in the guideline itself. So an auditing criteria was not given. Auditing was not mentioned at all in the guideline. So I've downgraded it to 5. The domain 6 is editorial independence. So this is where the conflict of interests are being mentioned. So the views of the funding body have not been influenced, have not influenced the content of the guideline. So the funding was done by the ACP operating budget, which is American College of Physicians' budget. I went into the guideline again to check where the money for the ACP guidelines come, because it's an association, and where do they get their money from. But they clearly mentioned that no industry funding is accepted for any stage of clinical guidelines. So it's more likely to be based on the registration fees and everything else which they get through the association itself, which was used for forming the guideline. And all financial and intellectual disclosures of interest were declared. There are no potential conflicts, which were also discussed and managed. They've also mentioned that CDC did not necessarily represent, we feel that probably one of the people who were part of the guideline review committee were part of CDC, but which was not mentioned, so we could not identify whether it was actually true. This was a line which we had a dilemma about. So last question is, competing interests of guideline group members have been recorded and addressed. So this is what conflicts of interest were. So Dr. Owens was a person who was actually part of one of the publications which was included in the guideline. So he was not given the authorship, and they have downgraded voting also. While Dr. Wilt was also given lower voting due to moderate level conflict, and they have disclosed everything in the journal. Like they put a separate article where they have disclosed every conflicts of interest and how they manage it also, which was appropriate. So once you've done all this, that's an exhaustive domain. So you have 23 items. So you can tabulate like this, and you can find out like each domain how much you have given. So the highest point is going to be 7 for each of this item, and lowest is going to be 1. So I mentioned how to go about tabulating it. So once you have tabulated, this is what the Agri tool gives. So ideally, it's supposed to be at least 2, or best is going to be 4 people appraising the guideline, tabulating it each domain wise, and finding out how good is the guideline. So they will add up each, and then they will divide it by the total maximum total, which is 84, and arrive at a percentage which gives you the quality of that domain itself. So I have done mine, so which are the percentage which with the rating I have done, I could find like each domain has 80, 85, 85, 85, 82 and 100% for each domain. Likewise, for 3 other people should do it, and then we should combine all results and find out if it's actually a good guideline. So this is the overall assessment of mine of the guideline, where I feel that it was not the highest possible quality. There were some pitfalls, there were some things which were not mentioned. So my rating would be 6 out of 7. And would I recommend the guidance as it is for use? No. I would like to have some modification based on Indian data, have some endeavor, and I'll just see like local people, local patients' perspective, which should be included into the guideline, and then maybe remodify it and then use it to us. So coming back to the clinical scenario, definitely the effect of SGLT2 or the clinical effectiveness, cost effectiveness is there, and I would actually start SGLT2 inhibitors after explaining the annual and future cost to the patient so that they understand what they cost, because the cost may not be the same as it is in US. They had a very high threshold which we discussed last week. So I will explain it to them and then start this drug for this patient is what I felt. Okay, as per this guideline. Thank you. Please visit our YouTube page also for rest of the clinical advice videos.
Thanks, Bennett, for the exhaustive presentation. So he has brought out all the components of a tool and how to the critically appraisal guideline. Any questions? Just ask a few questions. When you are reading a guideline, how do you see usually the recommendations are? You have read some guidelines. How are they written? Okay, there is a statement. There is a statement. What does that statement show? There was also something. Yes. So as Bennett mentioned, it says the specific population, what intervention you are looking at, and whether it is for or against, and what benefit or adverse effect that has. And there is also something called as what is the strength of recommendation. So this is a strong recommendation. Why? Because it also has got a high certainty of evidence. Because based on that systematic review and meta-analysis, for this particular one, there is a very high certainty of evidence. So on the basis of that, it has been rated as a strong recommendation. And if you want to actually look at what this certainty of evidence is, you can click this link and it will take you to the summary of findings statement, similar to what you would have seen in a systematic review meta-analysis, the summary of findings statement, based on which you will know that okay, it saves so many so many cardiovascular events, and this will be the number needed to treat, and this is the quality of evidence. So based on that, it is a high certainty evidence, and so I am going to give it as a strong recommendation. Suppose if the certainty of evidence is not high, if it is moderate, low or very low, what will that translate into? So what, instead of strong, how will they word it? Sorry? Weak recommendation. Okay, weak recommendation. Any other word that you have seen? That is a different way of classification. Here it can be weak or conditional recommendation. So either they used to say strong or weak. Instead of saying it's a weak recommendation, it's said as it's a conditional recommendation. So if the level of certainty is low, it may usually result in conditional recommendation. What is the difference between a strong recommendation and a conditional recommendation? Yes, so if it is a strong, if there is a strong recommendation, then it means that everybody should follow it, irrespective of whatever be the differences in characteristics, unless there is a potentially life-threatening complication or an adverse effect or a contraindication. In those cases you are justified in avoiding, but in all other situations you must. And if you don't do it, you are potentially to be facing medical legal consequences also. Say for example, if I am going to say MI and giving aspirin. If you don't give aspirin for a patient with MI, you are definitely liable for potential complications. You will not be able to sustain a legal or lawsuit also. So, if aspirin for MI, it will be a very strong recommendation. But whereas if it is a conditional recommendation, you can take in your expertise patients' values, preferences, everything together, like the evidence, like the three circles of evidence-informed healthcare, the available evidence, expertise, and patient preference. So it will be a overlap of this, that based on which you will take a decision. So that is what will be a conditional recommendation. Do high certainty of evidence always get translated into a strong recommendation? Suppose if there is a very high certainty of evidence, will it always be a strong recommendation? Yeah, just to give you an example, circumcision, does it reduce HIV transmission? Yes, it does. So there is good certainty of evidence to show that circumcision prevents HIV transmission. But if you go to Africa and say that everybody should, with HIV should have circumcision, it is not culturally acceptable. It may not be possible for them to apply it to all population, and if it becomes a strong recommendation, then it's a must, and everybody must be subjected to a circumcision of all individuals. If it is not going to be culturally appropriate, then they will have to only say that it will be a conditional recommendation, meaning whosoever is willing you can do, but you can't force everybody to undergo. So this is one example where you have a high certainty of evidence, but it gets translated only into a conditional recommendation. Another example is, what is the treatment for cerebral malaria? Artemisinin combination therapy. Is that the only treatment? Suppose if artemisinin is not available, what will you do? Sorry? For cerebral malaria. Something that you can give which may cause arrhythmias, hypoglycemias. Yes, so there is always some alternative. But when there is a comparison between artemisinin as well combination therapy and quinine, there is high certainty of evidence to say that ACT is better than quinine. That is evidence. But if you are going to make it as a strong recommendation, yes, based on this, you will have to make it as a strong recommendation. What happened was, when it was suggested as a strong recommendation in Africa, they were arguing, saying that quinine is available at next to nothing cost to them because the procurement and manufacturing is done locally. But whereas if they had to import artemisinin into them, it was resulting in so much of cost that they will not be able to provide basic sanitation, drinking water facilities and food for all others if they were to invest on getting ACT. So even though there is a high certainty of evidence to say that ACT is better, their guidelines state that it is only a conditional recommendation, meaning only if it is available you give ACT, but otherwise continue to give quinine, because for them it is not sustainable because of cost issues.
So that every country should make their own, like,
Yeah, this is the certainty of evidence. Then based on this evidence, every country will make their own guideline. So somewhere, say in the US or UK, definitely based on this evidence, they will say it's a strong recommendation. There, if you go and give quinine, they will be against whatever their practice is and they can't do it. Whereas in Africa, because it is not sustainable, it's not that it's an inferior treatment, just that it does not work as good as this. Quinine definitely saves lives, but just that it has got potential adverse effects. ACT is better, but they can't sustain by importing ACT. They can't provide for people what they deserve. When it comes to that, when it comes to their livelihood, they have to take a decision saying that they will continue to opt for quinine. So these are certain examples where Actually, certainty of evidence do not go hand in hand with the strength of the documentation.